Check it out, John. Back by popular demand. Check it out, John. Are they crazy? Once again.
Hello, and welcome to WDCast. My name is Dan Stanek, and I lead the health and wellness practice at WD Partners. That is the sponsor of this podcast. And WD's tagline is innovation at scale. And in healthcare, WD is leading the charge in creating and scaling innovative, human-centered healthcare experiences. And because of that, we have a very special guest today. This is a person who is at the forefront of human-centered healthcare experiences, Rushika Fernandopulle, who is an MD and is CEO and co-founder of Iora Health. Rushika, how are you today?
I'm well, thank you, Dan.
Great. Thank you so much for joining us. We're very pleased to have you be a part of this and pleased to hear your perspectives on healthcare. We want to start a little bit by learning a little bit about you. So want to hear about your background. How did you get to where you are?
So I'm a primary care doctor. I was born in a place called Sri Lanka, and we came to this country when I was about 2.5 years old, grew up in Baltimore, Maryland, but I've been in Boston pretty much my whole adult life. I always knew I suspected I wanted to be a physician, but my third year of medical school was on the wards and realized how screwed up the system was. Despite good people and largely good intentions, the system wasn't working. So I decided I was going to dedicate my career to both continuing to practice medicine because I love seeing patients, but also trying to fix the system. And I did that in a variety of ways, including trying to do it through a consulting company, doing some policy work in DC, ran an academic sort of a health policy think tank at Harvard, and eventually came to the realization that maybe all those attempts, which were sort of tweaking the current system, weren't going to be good enough. And I just simply had to start over and try to build a different system from the ground up.
And so you had been practicing and doing that for about how long before you started Iora?
So I'd been in practice for several years at a typical academic health center in Boston. I actually remember really clearly, it was a February night in Boston. Any of you who live in the Northeast knows in February, it's cold, it's dark.
Oh, yeah.
I had 20 something or 30 patients booked and barely had time to, go to the bathroom, let alone have lunch. And I couldn't finish all my notes because they put this new computer system in, which was really a pain to use. So I had to stay 2 hours after work, like everyone else, to finish my notes, or I'd get yelled at for not meeting my, productivity requirements. And I remember a colleague sitting next to me, and she said something very profound. She said, "Rushika, every day I lose a little piece of my soul." Ooh. Every day. We went into this to help people, and people come to us with such big needs, and we just can't do it given the current system. And this was the most damning line, and it's getting worse and not better. And that's what I realized, this I couldn't spend the rest of my career beating my head against a wall. I think that's what a lot of people in medicine feel like. I think we just need to change the system. And that's what set me on the journey that ended up at Iora.
Wow. So what was that process like? I mean, it's one thing to say, hey, I'm gonna change the system. It's another thing to do it. How did you actually pull that off?
Yeah, so the core premise was that maybe what we needed to do was a big change and not little change. I think what everyone else in the industry was saying is, it's too hard to change everything, so let's change something little. And somehow some of these little changes will lead to transformation. And what I realized is maybe the system is rotten to the core. And maybe what we need to do is simply rethink it and build a vision of where we're going, and maybe not necessarily start with what we have. Right. And create a vision of where we're going. One of my favorite quotes is from the Cheshire Cat. And he said, "If you don't know where you're going, all roads will lead you there." So maybe we need to create a vision of where we're going. A lot of people have these thoughts. I happen to be lucky enough at the time to be spending a bunch of my time running this interfaculty health policy program at Harvard. So at Harvard's time, I was able to say, what would I do if I was going to start over and build a new model, and was able to sort of go around the country and learn from people who are doing interesting things and call people together and do some really interesting brainstorming based on the Skunk Works process, as you probably are familiar with, to think what if Imagineering and what if you didn't have constraints, and came up with these models. This is what we do if we were going to start and rebuild healthcare. And one of the premises was we're going to rebuild healthcare instead of starting top down with the health system. No offense to my friends in health systems, but what if you start bottom up, start with the consumer or the patient or the person and build up from there? And primary care was the closest to the patient, consumer, person. And so let's actually start there and redesign primary care to help people with all this. So that's really what I had the time and the luxury to be able to do that. And then what I did is I went around to all the big health systems in town here in Boston and said, I've been doing this work at Harvard and coming up with this completely different model of primary care. Will you let me build it? And they all sort of pat me on the head and they said, that's really interesting, but our practices are full. We're making money. What's the problem? And I said, well, care sucks. Patients hate it. Doctors hate it. It's bankrupting the country. But then I realized that's not any of their problems, right? Practices full of money. So that's when I decided, like everyone who's been a little entrepreneurial, at some point you just have to take the leap and say, wait a second, I'm a doc. I can start a practice. I'm just going to quit my day job and start a practice and try to do this and see where it leads.
So it started as a single practice.
You started a single practice called Renaissance Health, the rebirth of primary care. By the way, bad idea, because while it's a good idea, I can't spell Renaissance. That two S. So in retrospect, was it not a great idea? But in any case, Renaissance Health, rebirth of primary care. It was in a place called Arlington, Massachusetts, just outside of Boston. And we said, we're just going to start over and break what people think are rules and figure this stuff out.
So not everybody's going to be familiar with Iora who's listening to this. So what is Iora and what makes you different from the rest of healthcare?
Yes, Iora is a step in the evolution of the thing that started with that one practice. And eventually was, what if we did this at scale? What if we wanted to build a new model of care delivery? Our tagline is restoring humanity to healthcare, right? At core, the problem with the current US healthcare system is that it is transactional. Document code, bill next, document code, bill next. We've squeezed all the humanity out of it. It's all check boxes, it's rules. And unfortunately, in the end, the only way to actually create value in healthcare, the reason why we are hired by people is to make them healthier. Right? If we don't make actual people healthier, we're wasting our time. We seem to have forgotten that in healthcare, by the way. And to make people healthier, it's about relationship, right? The burden is chronic disease these days. It's living life. It's not acute problems. We do that perfectly fine. So we need to build a new relationship-based model of care. So what Iora has been trying to do is build and scale different sort of relationship-based care models. So we have about 50 practices around the country right now that are actually doing this. We're not talking about it. We're not thinking about it. This is, our theory of change. The vision and the reason we do this is to transform healthcare. It's not to make money. It's not to build a medical group. It's to transform healthcare. And our theory of change is what I call the Southwest Airlines theory of change, right? So US Airlines in 1980, high fares, crappy service. What changed? It wasn't consultants. It wasn't the government. It wasn't Delta and American waking up one day and deciding to be better. It was a new entrant coming in, doing something completely different, getting customers to vote with their feet. That let those customers have a better experience, lower fares, but kicked American and Delta in the behind and said, you better change, you're going to lose your business. And that's what we're trying to do, is how do we change the whole industry? Excellent.
So what do your patients feel is different? What's different to them about the experience?
Yeah, so if you want to say what is we're doing, I've used three words. It's consumer-centric, digital, and value-based. Right. So I'll take those in reverse in order. So the first is healthcare. I, the doctor, will improve your health. That's silly, right? Most of the things are that you, the patient, consumer, the person has to do, right? If you're diabetic, you have to check your blood sugars. You have to decide, not to eat the piece of cake. You've got to take your medicines. I can't do any of that for you, right? If you add up all the time you spend with me, Dan, you're going to get about an hour or two. That leaves 8,760 hours you don't spend with me. So really what we've got to do is the healthcare system is say that you, the patient, and your family and loved ones are going to manage your health. What we need to do is give you the tools to do so. So we need completely different philosophies. We need to engage you and give you a great experience so that you will do so, right? We can't do it for you. We then have to, the digital is, we have to really leverage the digital tools out there. It's ridiculous. And in 2021, we are making people come in to get their lab results. We're using faxes, for God's sake, right? We're managing hypertension with one number every 3 months when you happen to be in the office, which is your blood pressure. It's ridiculous, right? Completely ridiculous that we do that. And then really value-based, that, the part of the core of the problem in US healthcare is the way we pay for it. We pay what's called fee for service, where we paid per doctor sick visit, and these inane billing codes that we perseverate over. What it does is it encourages us to keep people siep. So ironically,
there's the incentive to it. Yeah.
Not only am I not incented to make you healthy, I'm disincented to make you healthy under the current payment model. So that's why we say we need to completely change the payment model. So that's what we do, really, is change everything: the payment, the process, the space design. All of it needs to be aligned around this new vision of care. Right. And that's we've been around. Iora has been around for 10 years. It takes a while. but it really leads to a very different process and outcomes.
Outstanding. As you know, WD is focused on creating consumer-centric or human-centric experiences like we do for our retail and food service clients and everybody else who people go to have great experiences. And we want to bring some of that human-centered nature to healthcare. Why do you feel that healthcare has been so reluctant to adapt these kinds of principles, these kinds of human-centered principles?
Yeah, I think it's probably three things, Dan. I think one is the payment model. Right. So that, as I said, you get paid for doing more stuff to people. And I think that we need a different payment models to encourage this. Number two is, I think, just deep culture, that there is this hierarchical culture, this power dynamic that goes on in healthcare. The doctor's in charge. For instance, the fact that we have waiting rooms means that we value the doctor's time. We don't value the customer's time. Exactly. Right. If we value the culture's time, we wouldn't have waiting rooms. Right. We'd have us wait for them, not the other way around. So it's sort of deeply cultural. And then finally, I think it's an utter failure of leadership in healthcare, right? We all took oaths to serve our patients, and we seem to have forgotten that in general. And so I think it's a deep-seated problem. I think it's slowly changing. I think increasingly this is becoming a more competitive market. By the way, who figures this out? It's the customers. And I think to the extent that there are people like us, hopefully, who figure out better models, customers, patients will start voting with their feet. I think it's generational. My kids are not going to put up with the crap that we make people put up with in healthcare. The waiting a long time, you can't see your medical record, you can't email me, all those things. They won't put up with that, right? So I think as the generations shift, more and more of the customers will vote with their feet. And if you're not with this program, you should not be surprised you don't have many customers left.
We've seen that happen already. We did a study looking at primary care, urgent care, and retail clinics, and we found that younger consumers were absolutely gravitating to those more convenient mechanisms. And urgent care became their primary care, is becoming their primary care, unfortunately, in many cases. So you mentioned how your payment model is different than most healthcare systems use. What can that model be used more broadly? What's preventing that model from being used more broadly instead of the fee for service?
Yeah, no, it absolutely can. And so really the sort of moniker is value-based payment. Right. And I think what it really means, I think there are sort of three pieces to it that we believe. The first is getting away from piecemeal payment, fee for service, paper thing we do. Don't pay me for process, pay me for outcomes. And pay me for the relationship, and stop with the stupid little 99213, 99214 codes. Like, stop the madness. Just let's simplify and get on with it. And so we, started in doing what's called primary care capitation. So in primary care, just give us a fixed amount to take care of the patient and let us get on with it. And now what we're doing is increasingly moving to what's called global risk, to say, tell you what, we're so confident by us doing this better primary care will help people lower their total spend. Why don't you just give us the whole healthcare dollar and let us get on with it? Now we don't have to ask the question, does some bureaucrat say we'll pay for this or not that? The question we have to ask is, will this help the patient? So now we're aligned with the consumer, and this all works. We also need to double down on primary care, by the way. Primary care is usually 5% of healthcare spend, and we say we should at least double down on it. It's ridiculous. And then finally, we should take away sort of dumb financial barriers that make it hard for patients to do things. Like, why are we putting copays on primary care? Why are we discouraging people from using it? Lots of evidence that it's actually beneficial. You should get more, not less, right? So there is no principled reason why everyone couldn't do this, right? Now, you can imagine there are a lot of vested interests, by the way, who don't really want to see things change. Mm-hmm. So I think that's the problem, not that anyone can't do this.
Now, your patients, the people who are using your service, are also using other health services. How do you accept accountability if they might go to an acute setting and something happens there? How does that happen?
Yeah, so what we think is that primary care, it's a rare primary care practice, but we think primary care is this amazing lever. Why is that? Because we can do the usual primary care stuff. So we can see people for acute problems, we can manage their chronic disease. Maybe more importantly, we can help them with what I call the upstream. So the things that actually influence health are things like how you eat, how you move, your relationships, how you sleep. If you look at some of the Blue Zone research of what causes people to age well, it's optimism, sense of purpose, social connection. We can help with all that, right? Those things have far bigger an impact on your health than anything we do in the medical system, far bigger. And then number two is, even if we do the best job we can, you're still going to need to see specialists, go to the hospital. We can be your advocate and help you navigate that. Good luck as a consumer trying to navigate that system yourself. All this talk of consumer-driven healthcare give you patient skin in the game. There are huge power asymmetries and huge information asymmetries that there's no way, even if you're a doctor, you can do that. But having someone like me, your primary care doctor, help you with that, we can. So that's why primary care is this lever to help you with the upstream and the downstream. That makes a significant income on total healthcare spend. So what we've said, so typical primary care is in a downward spiral. We get paid too little. It's only 5% of healthcare spend. So what we do a crappy job, right? In the 7-minute visits we have. So people go to the hospital in the ER too often when they don't need to. By the way, we've shown over and over again, we can reduce hospitalizations by 40%, 40.
Wow.
ER visits by 50%, lower total healthcare spending by 20%, right? These are big numbers. We can do it over and over again. And other people too, right, who do what we do. So pay too little primary care, do a crappy job, go to the hospital in the ER, healthcare costs go up. What do the payers do? They lower our payment. Now we have 6-minute see people, right? So we're in this downward spiral.
Yeah.
So the bet we've made is turn the spiral the other way. Let's invest more in primary care, do it right, improve people's health, keep them out of the hospital, lower healthcare costs. And because we're at global risk, we get to capture that and got to invest more in spending more time with them and better systems, lower healthcare costs, get lower hospitalization, make more money, invest it back in them, right? So now the cycle is turning the other way.
Is it the fee for service model? Is it the payment model that is preventing these, like you said, the blue zone and the wellness types of services, the things that keep you healthier? Is it the payment model that's preventing providers from offering those services?
So it's certainly one of the things that's doing it. But it's necessary but not sufficient, right? So if one starts with getting new payment, now what you need to do is completely change your process of care, right? If you look at most primary care practice, 7-minute visits, there's one MA, the patient walks in, they get put in a paper gown, their butt's hanging out, doctor spends 7 minutes while they're standing up with their hand on the door. Like that process doesn't work, right? So now that you have a different payment model, you have to evolve a completely different delivery model. So the core to our model is a very robust team, right? So remember, as opposed to a typical doctor who gets paid for telling you what to do, right? You come in, I tell you, Dan, you should eat less, exercise more, take your medicine. Good luck, sucker. I'll see you in 3 months. That's all the time I have.
Right.
3 months later, you come back, you bad, non-compliant patient. I told you, it's completely ridiculous. Right? So what we get paid for is not to tell you what to do. And by the way, I submit a bill and a code for telling you what to do, and I turn my brain off. What we do is we're on the hook for you actually taking your medicines and cutting down on the salt and not getting that stroke and not ending up in the hospital. So it behooves us to actually engage you in executing, right? The problem in healthcare in general, in primary care, is not figuring out what to do. The problem is helping people to do it. If it was that easy to do the right thing, we'd all be doing it, right? Obviously, it's not easy. And so that's why we've evolved these health coaches who are really from the community, whose job it is to help the patient execute on the plan, hold their hand when that's the right thing to do, kick you in the behind a little bit when it's the right thing to do, understand your condition, check up on you, answer questions. So we have several health coaches per doctor. We embed mental health, integrated behavioral health into the model. We have social workers to help you if there are social barriers. We send a ride if you need a ride to pick you up to come in to see us, right? What are the barriers? How do we fix them? We'll see you in an omni-channel way. So we will do video chats and text messages and emails, and we'll go to your house if we need to, right? Just do what it takes to actually help you improve your health.
Wow. Obviously, healthcare is a big topic of discussion in Washington and a big topic of discussion in the US. I think people recognize that it's broken. What do you see as the key problems, and how do you see the country resolving these issues?
Yes, I think we're focused on the wrong thing. There's a lot of talk in Washington about, this Medicare for all, and it's somehow if we just sort of give people universal access, we'll fix the problem, which is not at all, by the way, to say that it's a travesty. The rich country that there are people who are uninsured in this country is, it's a moral outrage. That said, simply giving people access to the same crap we have now won't fix the problem. Right. So I think the core is we need to fundamentally change our delivery system, right? What we've done in this country at a very high level is we have created sort of a medical industrial complex, which is, and it's everyone's cahoots, the doctor groups, the hospitals, the health plans, the health systems, pharma companies, and they all make more money by doing more stuff to people and keeping people sick, right? And that just is what it is. I think we need to completely change how we align our health system to actually focus and reward health and not sickness. And that requires, unfortunately, a really big change. And by the way, simply having Medicare for all doesn't fix that problem, right? I think we're just talking about the fundamentally wrong thing is how do we fundamentally change the experience of care to focus on health? And no one's really having that conversation.
Focus on health. What a novel concept. You must have gone to Harvard. If I'm a listener and I'm a consumer, what can I do? If I'm fed up with the current system, what can I do to change that?
Yeah, the best thing you can do as a consumer is vote with your feet, right? I mean, that we have that power to vote with our feet. I would argue that that's the only thing that's changed most industries. I find it very hard to believe. Remember, I told you I doubted American and Delta are just going to decide to get better. I think the current healthcare system, left its own devices, will have a lot of rhetoric about change, but isn't going to change anything. Of course they won't. I think the only thing that will make things happen is consumers voting with their feet. And so we like to think our little role is let's create some alternatives for people. We need to create set alternatives for them to vote with their feet. And now let's let them vote with their feet, right? If your doctor is not doing the right thing and not helping you improve your health, find a new one who will, right? And I think that will actually cause the system to change.
Obviously during the pandemic, we have had a lot more exposure. Everybody's had more exposure to virtual care and to telehealth. And also, simultaneously, we've seen an explosion of wearable devices, of Apple Watches and other, wearable devices and monitoring devices. And this really presents an opportunity for us to have a different kind of relationship with our patients, with our customers. This really can help us promote this continuous care, as you mentioned, with being able to monitor and look at how they live their life, not just how we're treating them when they're sick. Does that excite you? What excites you about that?
Yes, what excites me is, these were all trends that were happening before. And what's interesting is the pandemic just sped them up, right? They just sped up stuff by 5 or 10 years, maybe. And a lot of the barrier, so two things happened in the pandemic, three things actually. One was that we put in abeyance some of the stupid rules, which prevented people from doing some of this creative stuff. That because of the pandemic, we said, we're gonna put those on pause. By the way, the world didn't end. So a great example is sort of state-based regulation of telemedicine, right? So we have a practice up at Dartmouth, up in Hanover, New Hampshire. It's literally a few hundred yards. You could not quite throw a rock. It's less than a mile away from Vermont, right? Because it's just across the river. In theory, if a patient was living in Vermont, which many of our patients do, called us or tried to do a telemedicine visit, we couldn't do it because it's practicing medicine across the state line.
Unbelievable.
So the good news is during the pandemic, they said, okay, we're going to suspend all those stupid state-based telemedicine regulations. By the way, nothing bad happened. So hopefully we'll keep that. Number two is I think doctors realized they had to do this, right? Or else they weren't going to get any income. But the most profound change is that consumers went along with it, right? So many patients and consumers who were reluctant to try something different, they sort of had to, like, I don't want to get COVID. Like, of course I'll try it. Now they tried it. Wait, this was not only that bad, this is maybe pretty good. I'd love to keep doing that. That genie's out of the bottle at the moment. Right. And I think that's what changed. So I think this idea that we need to think broadly about health, that this is about a continuous healing relationship, that's the Institute of Medicine's words, that we get data from people throughout their life, not just when they're in my office, that we actually are able to communicate with them in a variety of ways, by text, by email, by video, by phone, in person, and that we combine those into one experience to actually optimize health. That's really exciting. That's what we all should be doing.
Are there other technologies that are on the horizon that you get excited about?
Yeah, no. So I think a number of these passive monitors are really interesting. Again, in some ways, managing our health is a data-intensive business. Yeah. I think the way we've been managing hypertension is I make you come into my office literally 3 times a year. I put a cuff on and check your blood pressure in my office, and I make decisions based on that. Completely crazy, right? Who cares what your blood pressure is in my office? What I care about is what's your blood pressure throughout the day. And I bet you, as we start getting more of this information, we'll realize that actually the average blood pressure doesn't matter. Maybe the variation in blood pressure, maybe some other combination of things. That's exciting. I think the other thing that's really exciting is some of the advances in genomics and proteomics that really let us customize treatments. Again, it's ridiculous that we make one size fits all pronouncement. We say every woman should get a mammogram every 2 years, right? Well, yes, that's the average. For some people, that's way too often. They have zero risk of getting breast cancer because they have no genetic predisposition. We should get one every 10 years. There are other people who every 2 years is not often enough. We better keep them on much tighter surveillance because they've got a strong family history, right? So I think it's, we do a drug trial and we show that 51% of people benefit from this drug. So we give it to everyone. For 49% of the people, it is at least non-effective, may even be harmful. So more and more we'll be able to figure out for you, Dan, this is the right way we ought to monitor you. This is the right way we ought to treat you. These drugs work for you, these drugs don't, and be able to personalize these recommendations. That's a sea change of how we think about medicine. And I think that's coming, certainly in our lifetime.
Very refreshing. Very, very good. Awesome so far. Just I got a couple of softball questions for you. So, one is, where does Iora go next? What's next for Iora?
Yeah, so we're continuing to try to evolve our care model, right? So we can keep getting better. Really, one of the movements is how do we continue to get patients to play a more active role in their healthcare and really think about it. In every other industry in the world, we, the consumer, are taking on more of the role, right? When's the last time you saw a travel agent? When's the last time you saw a teller at a bank? And we've been given tools that allow us to do this, a stacked stock portfolio, right?
Right.
Over and over again, doing your shopping at Amazon. Like, you can compare, you can make decisions. We have systematically kept consumers out of being able to do stuff in healthcare. Treat my own UTI, manage my own blood pressure, manage my own diabetes. In some ways, you can become a better expert at your diabetes than I ever can. Your diabetes, and by the way, you've invested interest in it. So I think that's one, is how do we continue to go down this tool to let consumers have a more active role in their healthcare? It's better for the system. It's better for you. It'll lead to better outcomes, lower costs, all of those things. And we're going to keep spreading. I think we're going to keep opening new places. We're in 10 different markets right now. There are more places we'll go. And something really exciting is, I think the core of this, we have to get paid differently to do this. And so really one of the barriers has been getting payers to be willing to pay us differently. And we've done that through a number of self-insured employers. We've done that with a lot of Medicare Advantage insurers. The really exciting thing is starting April 1st, so starting just a few days ago, we now can go directly to the federal government and they'll do it directly with us for everyone on original Medicare, to 40 million people. So more and more, we're getting more payers to be able to wake up and say, we should do this more. And then someday we'll go global. Someday you think the problems we're solving, which are really about managing chronic disease and aging populations, we don't have a monopoly on in the US, and is there stuff we could do in other countries?
That's awesome. Well, thank you so much. And so finally, you are a practicing physician at the same time as you're the CEO of a company. How do you do that? How do you manage to, serve your practice time as well as then your company management time?
Yeah, no, so I do it because A, I like practicing, because that's why I went into this. And B, I think it gives me a great perspective. I think, unfortunately, we are a physician-led company, started company. I think that's really important. It's important about our values, important about why we're doing this. I think, unfortunately, when you stop seeing patients, the thing that happens very quickly is you start thinking this is easy, and that it's not. This is a very human thing. It's really complicated and really tricky. And you get reminded of that every time you see patients. And I don't obviously keep a panel of patients, who I do longitudinally. What I do is I do fill-in work. This Wednesday, I'm going to sub in for one of our docs in Hyannis. So what I do is, as often as I can, if someone's on vacation or whatever, I'll say, hey, I'll come and be the doctor. I put my little stethoscope on, put my name tag on, team physician, and go in and play doctor. And it's great. Teams like it. I like it.
Fantastic. Well, thank you so much. That's all I have for you today, but you've been very gracious, and we really, really appreciate your excellent perspectives and opinions on healthcare and on the consumerization and human-centeredness of healthcare. People in the audience, please be sure to continue to listen to WDCast. We've got lots of other valuable content that we're going to be coming out with, and extremely interesting guests, just like you've seen with Rushika. In fact, our next healthcare guest is going to be Marcus Osborne, who is the Senior Vice President of Walmart Health. And I think he's going to have some very interesting perspectives to share as well. And also be sure to subscribe to this podcast, which is at WDPartners.com. You can go to the podcast icon that's down at the bottom of the page, and it's in the navigation scheme there. So CEOs, entrepreneurs, artists, retailers, lots of good learning for all of our audience there. We're really happy to have you and hope you take away some valuable lessons from these podcasts. So thank you so much for tuning in and listening, and remember to think big and act fast. Thank you. Bye-bye.
Ladies and gentlemen, check it out, y'all.